Hello everybody. Today we are going to discuss the community acquired pneumonia. So we have this 43-year-old female patient who is a known case of hypothyroidism, obstructive sleep apnea. She presented to us with the chief complaint of fever since 4 days, cough, backache. Initially went to local hospital and chest X-ray was suggestive of bilateral infiltration. Then she came to our hospital for the further management. So on arrival, patient was in severe respiratory distress, not maintaining saturation. So chest X-ray was taken in ER, which showed the bilateral infiltration. So this was the chest X-ray of that patient, which was suggestive of the ARDS type of the picture. And on the patient was in severe respiratory distress, requiring the 80% FiO2 on NIV. So in view of respiratory distress desaturation, we have intubated this patient. So initial working diagnosis of this patient was acute respiratory distress syndrome. The PF ratio when we calculated it was less than 150. So prone position was given to this patient. So after proning her, the FiO2 requirement was reduced to 50% and PF ratio was 300. So CT, we had done the CT scan of this chest, which suggestive of consolidation. So to find out the cause of ARDS, we have sent the investigation. And we were also thinking about the underlying pneumonia, which must have progressed to the ARDS. So we have sent this respiratory biofile and respiratory urinary antigen for streptococcus antigen, which came out to be positive, and also the respiratory biofile showed the streptococcus pneumonia. So we have treated her with Zostem, Claribid, hydrocort, and nebulization. And her chest X-ray was better, and she was extubated on day 7. So this was the case which we initially thought it was ARDS, but it was not ARDS. It was a simple community acquired pneumonia. So next we have a patient who was a 64-year-old female patient who was a known case of rheumatoid arthritis on medication. Presented to us with the sudden onset of breathing difficulty and cough since 2 days, fever since 3 days, and she was also complaining of chest pain. So initially, patient was requiring the 2 liters of O2, and later her O2 requirement increased gradually, and the patient was shifted to N. So this was the chest X-ray of this patient, which was suggestive of community acquired pneumonia. Pneumonia severity index score was 55. So her chest X-ray was worsening gradually, and patient was intubated in view of high FiO2 requirement. And then patient was diagnosed with the acute respiratory distress syndrome. She received the 7 cycles of the proning session. Her ET culture showed stenotrophoma maltophilia, which we have treated with the appropriate antibiotic. On repeating ET culture, there was a growth of Klebsiella pneumoniae, which was a carbapenem resistant. And patient was extubated successfully on day 10. So this was the treatment line of that patient, which she received in the form of clotrim, minocycline, zavicefta, astrum. So this was the case where the patient was initially presented as community acquired pneumonia and later progressed to ARDS. So we will see what is community acquired pneumonia. Community acquired pneumonia is the acute infection of the pulmonary parenchyma in a patient who has acquired infection in the community. Factors that increases the risk of community acquired pneumonia are advanced age, chronic lung disease, chronic heart disease, cardiovascular disease, diabetes mellitus, malnutrition, then viral respiratory tract infection, then immunocompromised condition, and lifestyle factors such as smoking and excessive alcohol consumption. Now, regarding pathogenesis of the CAP, development of the pneumonia is influenced by the combination of factors, including host susceptibility, pathogen virulence, and the inoculum of microorganism reaching to the lower air. So, respiratory pathogen must overcome several defense mechanisms of the respiratory system before reaching the alveoli. And these differences include mucus trapping, mucociliary clearance, coughing, and swallowing. And pathogen can reach alveoli by means of microaspiration, inhalation, macroaspiration, and hematogen spray. So microaspiration is the primary path for microorganism into lung, and macroaspiration may lead to aspiration pneumonia. The alveolar macrophages is the primary defense mechanism in the lung. So if pathogen overcomes this alveolar defense mechanism, then they will multiply and cause local tissue damage. Then the injured tissue cells then produce damage-associated molecular pattern, which further stimulate alveolar macrophages to produce cytokines and chemokines, which trigger local inflammatory response. So gradually there will be the cytokine spillover into bloodstream, which results into the systemic inflammatory response. So the initial systemic inflammatory response can become dysregulated, result in tissue injury and eventually organ damage. So inflammatory response explain most of the host patient's sign and symptom as well as lab and imaging abnormality. So this is the progression of the um, community acquired pneumonia to severe community acquired pneumonia. So first there is a local damage lung alveoli. Then there will be the production of cytokines, chemokines, which happen because of the activation of macrophages because of damage associated pathogen molecule. Then there is a product because of this activated macrophages, there will be the production of cytokines, chemokines, which is responsible for systemic inflammatory response and further organ dysfunction. And if it is involving multiple organ like heart, lung, kidney, CNS, blood, and liver, then it results into the multiple organ dysfunction syndrome. So we'll see what are the respiratory pathogens responsible for the community acquired pneumonia. So it includes gram-positive bacteria like MSSA, Streptococcus pyogen, Streptococcus pneumoniae. Gram-negative bacteria like H. influenza, Moraxella, and Enterobacter. Atypical bacteria like Legionella, Mycoplasma, Chlamydia, and respiratory viruses like respiratory syncytial virus, influenza virus, parainfluenza virus, human metapneumovirus, rhinovirus, and common human coronavirus. Uncommon and infrequent bacteria include gram-positive bacteria like MRSA, Nocardia species, Rhodococcus, gram-negative bacteria like ESBL, CRE, Francinella tularensis, atypical bacteria like Chlamydia, Psittaci, Coxella burnetii, Mycobacterium like Mycobacteria TB, non-tuberculous mycobacteria, viruses which include cytomegalovirus, herpes simplex virus, varicella zoster virus, fungus like Pneumocystis jirovecii, Aspergillus, Mucorale, Histoplasma, Cryptococcus, and parasites like strongyloids and toxoplasma. So signs and symptoms include cough, shortness of breath, sputum production, fever, chills, malaise, anorexia. And signs are dullness to percussion, rales, crackles, tachycardia, hypoxemia, leukocytosis, pulmonary infiltrate, increased CRP, and ESR. So this is the radiology chest X-ray of the community acquired patient. Will look like this. And the if you will to label it as community acquired pneumonia, there should be the proper clinical presentation which include cough, fever with radiological evidence. Then we can say it is pneumonia. So once the pneumonia is diagnosed, our next job is to find out how severe pneumonia is. And to find out that, we have two scoring systems, which is CURB 65 and Pneumonia Severity Index. So we'll see what is the CURB 65. CURB 65, the total score ranges from the 0 to 5. And the each one score is given to the each component. C is new onset confusion. U is blood urea nitrogen greater than 90. Respiratory rate greater than 30 breaths. systolic blood pressure less than 90, diastolic blood pressure less than 60, and age 65 years or older. So if this curve 65 score is 0 to 1, we can treat the patient on outpatient basis. If the patient score is 2, then patient may require close observation and short hospital stay. And long-term hospitalization is required if the score is 3 to 5. Then the next score is pneumonia severity index. The component of the pneumonia severity index is according to the sex. If women, then 10 points. If nursing home resident, then 10 points. Then according to the coexisting illness, if neoplastic disease, 30 points. Liver disease, 20 point. Congestive heart failure, 10 point. Severe, 10 point. And renal disease, 10 point. According to the physical examination, altered mental status, 20 points. Respiratory rate more than 30, 20 points. SBP less than 90, 20 point. Body temperature less than 35, more than 40, 15 points. Heart rate more than or equal to 125, 15 points. Then according to the lab and chest X-ray finding, if arterial pH less than 7.35, 30 points. Blood urea nitrogen more than 30, 20 point. Sodium less than 130, 20 point. Glucose more than 250, 10 points. Hematocrit more than 30%, 10 points. PaO2 less than 60, 10 points. And if there is presence of the pleural effusion, then 10 points. So if this score is between 50 to 70, then we can manage the patient on the outpatient basis. 71 to 90 is somewhat intermediate score, so we can take the proper decision whether we should discharge the patient or manage on outpatient basis, or whether we should admit the patient for short stay. If the score is between 90 to 130, then definitive admission is required. And if it is more than 130, then it is associated with high mortality rate of 27% and patient needs ICU admission. So we'll see what is this severe pneumonia, non-severe pneumonia according to IDS. So IDSA has made things very simple for us. They said, according to the IDSA, if the community-acquired pneumonia is severe, if it is satisfying the major criteria, like septic shock with the need of vasopressor and respiratory failure requiring mechanical ventilation. And the other minor criteria, according to IDSA, if these two criteria are present, then no doubt we have to shift the patient to ICU because it is a severe. And according to IDSA, the minor criteria are respiratory rate more than 30, PO to FiO2 ratio less than 250, multilobar infiltrate, confusion disorientation, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension. IDSA, now we'll see what are the IDSA recommendations for site of care. So they said ki use for determining the site of care. That means whether we should manage the patient on OPD basis, IPD basis, or ICU. We should use the pneumonia severity index over curve 65. And for ICU admission is there are only two criteria: hypotension requiring vasopressor, respiratory failure requiring mechanical ventilation. So after diagnosing and after deciding where to admit patient, our next step is to send lab investigation. And the available recommended tests include sputum gram staining, culture, blood culture, using immunochromatographic analysis for Streptococcus pneumoniae, Legionella pneumophila serotype, and molecular techniques such as multiplex assays such as SAS. So if we are suspecting the MRSA, then we should then send the nasal swab for MRSA PCR. And since the negative result, and if the result is negative, we can discontinue the treatment which we have started for MRSA. A more comprehensive microbiological workup should be performed on the basis of epidemiological exposure and individual characteristics such as immunosuppression. So on routine basis, we should not obtain sputum gram stain and culture if we manage the patient on the outpatient side. And it is recommended to obtain the Gram-Stein and culture of respiratory secretion in adult with the CAP managed in hospital setting who are admitted with the severe community acquired pneumonia. If we are empirically treating them for MRSA and Pseudomonas aeruginosa, they were previously infected with Pseudomonas aeruginosa and MRSA, especially those with prior respiratory tract infection and who are hospitalized and receive parenteral antibiotic in last 90 days. Then urine test for Legionella and Streptococcus antigen is not recommended routinely. It is only recommended in severe community acquired pneumonia and in cases where there is a epidemiological factor such as association with the Legionella outbreak and recent. If the influenza virus is circulating in community, it is recommended to test for influenza also. What is the role of PCT according to ITs? So the role of PCT is we don't take the decision of starting antibiotic on the basis of PCT. If on the basis of if clinically and if we have enough radiological evidence, then don't delay antibiotic administration just because PCT is negative. Now the next line of investigation is the ultrasound. So ultrasound, it is the one of the investigation which we commonly perform in ICU on bedside. And yes, with the help of these two, we can diagnose the pneumonia on bedside only and very easy. So for that, we should be aware of what is A profile, what is B profile, what is AB profile, and what is A dash and B dash profile. So first we need to determine what is if there is a lung slide is there or not. If lung slide is there and if that is showing the B line, then it is pulmonary. If lung slide is there and if there is A line, then it could be pneumonia. For that, or it could be pulmonary embolism also. For that, we need to obtain the PLAPS. If the PLAPS are if PLAPS is present, that means it is pneumonia. And if PLAPS is absent, then it is a COPD or asthma. If AB profile or C profile is there, then without lung slide, with lung slide, then it is pneumonia. And if lung slide is absent, and if there is a absent of the B profile, then also diagnosis is the pneumonia. And if lung slide is absent, and if there is a presence of this A profile, then we can label it as pneumothorax. So this is the presence of the B line without lung slide. This is the lung ultrasound picture of the community acquired pneumonia where we can see absent lung slide and the presence of the B line, which is an indicative of the pneumonia. Now, what is a Schrader sign? Schrader sign is a very popular sign in the pneumonia. So what is it? So Schrader sign will produce when the consolidation does not involve entire lobe of the lung and it creates the shredded and the fractal boundary between consolidation and underlying aerated lung. So this is the picture which is on the left side or right side of the screen showed the ultrasound image of community acquired pneumonia. And on the left side, we have obtained the bedside ultrasound of that patient, which was looking like shreds. So this is this large starry sky appearance will produce when there is a large lobar consolidation with serrated margin. And our ultrasound was also looking like some starry sky appearance like picture because it was large pneumonia. Now, after diagnosing, after categorizing the patient, after deciding the place of the treatment, the next job is to give the appropriate treatment targeting the first common pathogen and based on the severity. Okay. So if we are planning to treat the patient on the outpatient basis, and if the patient is young without any comorbidities, And if we think the patient is not immunocompromised, then we can start with simple amoxicillin, that is 1 gram 3 times daily, or we can discharge him with the doxycycline, that is 100 mg daily, or macrolide, that is in the form of azithromycin at the dose of 500 mg on one day, then 250 mg daily, or we can also use clarithromycin 500 mg twice daily, and extended release clarithromycin, that is 1,000. So macrolides should be prescribed only in areas where the pneumococcal resistance to the macrolide is less than 30%, which exclude United States where the resistance exceeds 30%. So if we are planning to treat the patient on outpatient basis, and if the patient is old with a lots of comorbidities like chronic heart disease, lung disease, renal disease, diabetes mellitus, alcoholism, malignancy, and osteopenia, then we can start combination therapy of BLBLI, that is amoxicillin clavunet, that is in the dose that we can use is 500 to 125 mg 3 times daily, or amoxicillin clownate 875 mg by 125 mg twice daily, or 2000 mg twice daily, or we can use cephalosporin. And and along with that, along with this BL-BLI combination, we need to prescribe macrolide in the form of azithromycin, clarithromycin, or doxycycline, that is 100 mg twice daily. Or we can simply discharge the patient with the monotherapy, that is respiratory fluoroquinolone, that is levofloxacin 750 mg daily, moxifloxacin 400 mg daily, or gemifloxacin 320 mg daily. If patient cannot take beta-lactam agent owing to hypersensitivity and adverse event, then we can prescribe the fluoroquinolones, that is levofloxacin 750 mg daily and moxifloxacin 400 mg daily, or one or more recently approved agent like lefamulin and omadacycline. But in country like India where TB is prevalent, always prefer macrolide over fluoroquinolones. If the patient is under the category of non-severe CAP without risk of MRSA and Pseudomonas aeruginosa, but if we are planning to give this, if we are planning to admit this patient, then we need to start with combination therapy of the beta lactam and macrolide, or monotherapy of fluoroquine. Again, prefer combination therapy of beta lactam or and macrolide over fluoroquinolone monotherapy in country like India because of the TB prevalence. And the additional use of the macrolide is it has an anti-inflammatory and immunomodulatory property. Third option for patient with the CAP with to have contraindication to both macrolide and fluoroquinolone is combination therapy with beta-lactam uh, and doxycycline 100 mg twice daily. If the patient has severe CAP without risk factor for MRSA, then the treatment line will be beta-lactam plus macrolide and beta-lactam plus respiratory fluoroquine. So we can give empirical coverage of the MRSA and Pseudomonas if the risk factor for MRSA and Pseudomonas are present, like residence in the nursing home and other long-term facility, hospitalization for more than 2 days in last 90 days, recipient of home infusion therapy, chronic dialysis, home wound care, and a family member with a known antibiotic resistant pathogen. Empirical treatment option for MRSA include vancomycin 15 mg per kg every 12 hourly and linezolid 600 mg every 12. Empirical treatment option for Pseudomonas aeruginosa include piperacillin tazobactam 4.5 gram every 6 hourly, cefepime 2 gram every 8 hourly, ceftazidime 2 gram every 8 hourly, aztreonam 2 gram every 8 hourly, meropenem 1 gram every 8 hourly, imipenem 500 mg every 6 hours. Now, when to add anaerobic coverage? Anaerobic coverage, no need to add anaerobic coverage until and unless we are suspecting lung abscess and empire. Regarding anti-influenza treatment, if the patient of community acquired pneumonia who tests positive for the influenza on outside outpatient setting, Then only add the anti-influenza treatment like oseltamivir. Standard antibacterial treatment should be initially prescribed for adults with the clinical and radiological evidence of CAP who test positive for influenza in inpatient and outpatient setting. Now, regarding the recommendation of the corticosteroid, according to IDSA, the routine use of corticosteroid is not recommended for severe and non-severe CAP. But one trial which was recently published in NEJM, that is Cape Cod trial, which was in the favor of using corticosteroid in severe community acquired pneumonia. Plus, there is no role of corticosteroid in severe influenza. And if we are planning to add corticosteroid, then it should be according to the surviving sepsis campaign guideline if the patient of the CAP presents with the refractory septic shock. These are the evidence of the CAP, that is CAP START trial, which was published in 2015. So according to this, patient with the clinically suspected CAP admitted to the non-ICU wards, a strategy of preferred empirical treatment with beta-lactam monotherapy was non-inferior to the strategies with the beta-lactam macrolide combination or fluoroquinolone monotherapy. Then OPTIC trial, which was published in 2019, omedocycline was non-inferior to moxifloxacin for treatment of community-acquired pneumonia. Then Cape Cod trial is in the favor of using hydrocortisone in severe community-acquired pneumonia. And in 2024, diagnostic stewardship in community-acquired pneumonia with syndromic molecular testing. And the result of this RCT indicates that routine deployment of PCR testing for lower respiratory tract pathogen lead to faster and more targeted molecular microbial treatment for patients with suspected CAP. Thank you guys for paying attention.